Hello and welcome to Anatomy of the Knee. This is our final anatomy presentation of the semester. In this presentation, we will discuss distal femur anatomy, so we'll focus down here by the knee joint. We'll discuss proximal femur anatomy in Procedures 2 after winter break. Okay, so let's get started discussing the femur. So similar to all long bones, the body of the femur is the slender, elongated portion of the bone seen in the middle here. The distal femur, as viewed from the front, demonstrates the position of the patella or the kneecap. You can see that here. The patella, which by the way is the largest sesamoid bone in the body, is located anteriorly to the distal femur. And you can really appreciate that relationship when you look from a lateral perspective, and we'll do that in a little bit. The most distal part of the patella is superior or proximal or above the actual knee joint by about 1/2 inch when the lower leg is fully extended. So when there's no bend in the knee, the patella naturally sits about 1/2 inch above the knee joint. It's important for us to understand that relationship of the patella to the knee joint because it comes in handy when we're positioning the knee. The patellar surface is the smooth, shallow, triangular depression at the distal portion of the anterior femur. Okay, and I'll show you this again in another perspective, but patellar surface is going to be the area behind the patella on the distal femur. That patellar surface extends up under the lower part of the patella, and it's also sometimes referred to as the intercondylar sulcus or trochlear groove. I personally would like you to know all three of those terms, patellar surface, intercondylar sulcus, and trochlear groove, just in case you were to see them on a test. They all refer to the same smooth depression on the distal femur that articulates with the patella. The patella is usually above the patellar surface, again, when the lower leg is fully extended. But as you bend your knee or flex the knee joint, the patella, which is attached to a large tendon, moves downward over the patellar surface. And again, you can really visualize this relationship much easier on a lateral knee. Okay, lastly here, notice that in an upright anatomic position, when the femoral condyles are parallel to the floor, the femoral shaft is at an angle of approximately 10 degrees from vertical for an average adult. So let's say that again. When the patient is upright in anatomic position, and when the condyles, which you can see here, of the femur are parallel to the floor, you can see the shaft or the body forms a 10-degree angle from vertical. So here it's labeled 5 to 15, but approximately 10 degrees. The angle is greater on a person who is short in stature and has a wider pelvis, and the angle is less on a person who is of tall stature with a narrow pelvis. So in general, the angle is also greater on a woman than it is on a man, probably due to the width of the pelvis. Okay, so really it's just about understanding that the body of the femur is about 5 to 15 degrees from vertical. Okay, the posterior view of the distal femur best demonstrates two large rounded condyles that are separated by the deep intercondylar fossa or notch, above which is the popliteal surface. So let's say that again. On the posterior aspect of the distal femur, you can see these rounded condyles. And in the middle of the condyle is the intercondylar fossa or notch. And above that fossa is the popliteal surface of the distal femur. The rounded distal portions of the medial and lateral condyles contain smooth, articular surfaces for articulation with the tibia. The medial condyle extends lower and more distally than the lateral condyle when the femur is vertical. So remember on our previous slide, we noted that in anatomic position, the femur sits 5 to 15 degrees from vertical. This slide is saying that when the femur is vertical, you'll notice the medial condyle sits about 5 to 7 degrees lower or more distal than the lateral. It's this relationship that causes us to add a 5 to 7 degree cephalic tube angle for our lateral knee projections. And that is on patients that don't have a knee replacement. When patients have a knee replacement with hardware, we do not need a tube angle. The 5 to 7 degree cephalic tube angle causes the two condyles to then be directly superimposed when the femur is parallel to the image receptor. And we'll talk about that more in lab. A difference between the medial and lateral condyles is the presence of the adductor tubercle, which you can see here. The adductor tubercle is a slightly raised area that actually holds onto or receives the tendon of an adductor muscle. And the tubercle, this adductor tubercle, is present on the posterior lateral aspect of the medial condyle. It's not visible on an AP knee x-ray, and it shouldn't be visible on a correctly positioned lateral knee x-ray. You will see the adductor tubercle on a slightly rotated lateral knee, and we'll look at examples of that in lab. That is important for us to recognize so we know how to correct our positioning errors. The presence of the adductor tubercle on a lateral knee x-ray means you are under-rotated every time. You need to turn the patient more towards the image receptor. The medial and lateral epicondyles, which you can see here, remember epi meaning above the condyles, they can be palpated actually on the sides of your knees, and they are rough prominences for the attachments of the medial and lateral collateral ligaments and are located on the outermost portions of the condyles. The medial epicondyle, along with that adductor tubercle, is the more prominent of the two epicondyles. Okay, the lateral view here shows the relationship of the patella to the patellar surface that we discussed earlier. The patella, as we know, is a large sesamoid bone, and it is actually embedded in the tendon of the large quadriceps femoris muscle. Now, as the knee is bent or flexed, as you see here, the patella moves downward and is actually drawn inward into the intercondylar sulcus or groove. A partial flexion of about 45 degrees, which is what you see here, demonstrates the patella being pulled only partially downward, but if you were to flex the knee more, say 90 degrees, the patella would move down farther over the distal portion of the femur. Now, this movement of the patella downward as you flex the knee and the relationship of the patella to the distal femur becomes important in positioning for the knee joint and for the tangential projection of the patellofemoral knee joint, and we'll talk about that more in lab. Now remember, the posterior surface of the distal femur, just above the intercondylar fossa, is this popliteal surface. And it's this surface where popliteal blood vessels and nerves pass. Okay, if we look at the inferior view or the axial view of the distal femur, you can really appreciate that relationship between the patella and the patellar surface. And if you have seen a sunrise or a merchant's view of the knee at clinicals, this is exactly what we're looking at. So let's orientate ourselves. So here is anterior, here is posterior, and then of course medial and lateral are labeled for you. And again, you can really just appreciate the patellofemoral joint space in this axial or inferior projection. Okay, notice the intercondylar fossa. It's a very deep groove or fossa on the posterior aspect of the femur. And remember, it's going to be below this popliteal surface. You don't see it here on the lateral projection, but just to orientate yourself. So here's your intercondylar fossa. And then again, take a look at the epicondyles. Remember, they're rough prominences on the outermost tips of the condyles. So here's your medial epicondyle and here's your lateral epicondyle. This rounded surface here and here then would be your condyles. Okay, let's end part 1 by discussing the patella. Okay, so the patella is a flat, rather triangular shaped bone about 2 inches in diameter. And notice the top of the patella is this broad surface called the base, and the inferior aspect of the patella is pointed and called the apex. So it kind of looks upside down, but this is right. The bottom portion of the patella is the pointed portion. So, think about the fibula. The very top part of the fibula is the apex, and I think that can be confusing. So don't always associate apex with the top. Apex should refer to pointed, a pointed structure, if that helps you to remember that it's the bottom of the patella. Okay, let's look at the surfaces of the patella next. Notice the anterior surface, or the outer surface, is convex and rounded and rather rough. The inner or posterior surface is smoother and more oval-shaped because it articulates with the distal femur. The patella really serves to protect the anterior aspect of the knee joint, and it also serves as a pivot to increase leverage on that large quadriceps femoris muscle. The tendon of the quads muscle attaches to the tibial tuberosity of the tibia, remember, and the patella is embedded within that tendon. The patella is loose and movable in its more superior position. So in other words, when the leg is extended and the knee is not bent, the patella is pretty movable. But as soon as you bend that knee or flex that knee joint, the muscles tighten, the patella moves downward or distal and becomes more locked into position. It becomes less mobile. The patella, it's worth noting, only articulates with the femur. It does not articulate with the tibia. Okay. All right, so we're going to conclude part 1 here.